please make sure that you read over this chapter about managing cost and budgets, because that's a lot of what hospitals really operate around. And so it's very important to know why things are done the way they are and have an idea of some of the background work that goes into budgeting. You may hear of the gross domestic product, and they usually call it the GDP. They have a lot of initials about different things, just like how we do in healthcare. But the gross domestic products. And then they have the real gross domestic product, which is the output of goods and services that are produced by workloads and labor and also the property that's located in the United States. What happens is that data is going to reflect income as well as your expenditure flows. So whatever comes in and then how much you're spending, which is going out. The sectoral coverage includes durable and non-durable goods, structures, which is the buildings and grounds, and then services that are needed. Because of it's so detailed and the detail available in the gross domestic product reports, this provides companies with a comprehensive supply of information about their supply and demands, and includes information for various types of developing imbalances over the business cycle. And so you're going to look and see what's our supply and what are demands, what are we spending, and are we maybe spending too much and not getting enough in? Do we need to decrease the amount of supply because the demand has decreased? So it kind of goes back and forth, and this is how they make some of those judgment calls. This slide shows you about increased utilization of healthcare services. So you have things about unnecessary care, you see about healthcare financing, pharmaceutical usages, disease patterns, what is the population demographics. So as the percentage of the GDP, which is your gross domestic product, and remember that which is mainly the broadest measure of the health of the United States economy. What happens is as the percentage of this gross domestic product, they look at what is spent on health care, and as it rises, it becomes more likely that others, such as that are external to health care, will want to fix the situation. So the gross domestic product suggests that we must be engaged more actively in helping to change the healthcare system. And as you know, you can see some of the issues today with healthcare and services available, who has insurance, who does not. And so again, right now we have the government trying to fix the problem, but is that really going to help, and has it helped? I'll leave you up to your own thoughts about that. So are we getting what we pay for? So we have health disparities, and this depends on each person's their background, their makeup, their socioeconomic status. Also, in the United States, unfortunately, infant mortality is among the highest in the world just here in the United States, and life expectancy is lower than in many other developed countries. So, with these facts, it is clear that we're not receiving a high value for the amount of money that we spend on health care. When we look at healthcare financing, there's 4 sources that are listed here, and so you can see the percentages of what goes out. So there's 4 key sources. As you see, the government, primarily through Medicare and Medicaid programs, pays the most as a single source. Then you're going to have your private insurance companies. Even though they pay more of the overall percentage, they're composed of many numerous individual businesses that make them up. Almost 75% of the government spending is at the federal level. And because the government pays such a large percentage, you can see how Medicare, Medicaid services are greatly going to influence what happens with health care. Hence, some of the changes we've seen with Foley catheterizations and the infections and UTIs, wound care and skin breakdown, and why the hospitals have become so adamant about making sure we're turning those patients, preventing those infections, because they don't get those reimbursements from these companies. you've probably heard some maybe family members or other people out and about talking about their Medicare, Medicaid plans, and Medicare has the different parts, and sometimes it can be a bit confusing, and usually they have to have someone help them figure out which part they have of their Medicare. The primary payer of health insurance is Medicare. Part A is going to cover your organizational services such as hospitals and home health. The Part B is actually optional. It provides healthcare provider payments, medical equipment, and different diagnostic tests. So it depends on, the person's medical history and if they need that or not. Then in 2006, they came up with Part D, which they actually had several small offices set up around cities to help people figure this out. And it was the drug benefit. And that went into effect again, as I said, in 2006, because many people were, losing money and going almost bankrupt just trying to pay for their medical, not their medical expenses, but their medications that they needed. Medicaid, as you see here, is a state-level program, and its costs are shared between the state and the federal government. So funding from the federal level is dependent on the per capita income of that state. In addition to covering the medically indigent, who are the population the public usually thinks as being the targets for this program, Medicaid also covers people who have disabilities. Some payment methods that are listed here. You have your list here, and the charges are the cost of providing a service, plus they want to. There is a markup for profit. So usual and customary is the terms that means third-party players or payers, and they have surveyed providers in the area to establish what the payer will pay. So a hospital could tack on a markup and not necessarily receive it because it way exceeds the usual and customary charge. So that's why on payments, if you've ever noticed, this is what the charge was for the service you got, but your other payers, your third-party payers or your insurance will only pay this much. And so that's usually what the facility receives. So your cost-based reimbursement calculates all the allowable costs, and then it uses that as the basis for payment. So each payer is going to determine what the allowable costs are. So both of these approaches have been largely replaced by payer fee schedules. Then you have your flat rate reimbursement. And this is based on a payer's deciding in advance what the payment will be. If the costs are greater, the provider absorbs the cost. If the costs are less, the provider actually benefits. Your capitated, that not means decapitated, but your capitated payments are based on the provision of specified services to an individual over a set period of time, such as 1 year. The capitation, or the per head or per person fee, is set, and the desire is to provide needed care at the lowest possible cost while still meeting quality standards. Here we have managed care, and this is a plan that brings together a delivery and financing function as into one ball, okay? They're putting it all together, and what they're trying to do is they're trying to stop the unnecessary services that are out there, or at least decrease them. And if we can decrease them, then we can decrease the cost. So, when someone goes in with a problem with the bone or an arm, they have, okay, let's go to the doctor. Then we have the x-ray. Then you may have the CT scan. And then you have the MRI. Look at all those costs in between. What is it that they really need to find out what the problem is, instead of having to pay all these individual small tests to get to what they really need. If someone has a ligament damage, why have an x-ray that looks at the bone and not the ligaments? So here's some things to ponder. What does this mean for nursing? So we have to think of our practice as an organization that has viable and quality care. We must be able to think, about finances because it will affect us. It'll affect our institution. What if our institution closes down because they end up losing money instead of making money that keeps it running? We have to think about our services and our patients. They still, no matter what type of money, socioeconomic situation they're in, or whatever kind of plans they have, they still deserve to be treated and have our services. And we must also think about being cost conscious and thinking about when we're using materials, when we're using supplies and not wasting them, and knowing what's being charged to those patients. Every time you pull something out of a Pyxis, it goes to that patient's charge. Is it something that's necessary or not necessary? Also, we need to think about patient needs. It's not about the provider, it's not about the facility or the organization. It's about the patient and what do they need and how can they get the care they need. We also need to think about what are the best evidence-based practices out there, and who is it that we're serving, and looking at the research and finding out what is the best way to take care of these patients. So we're not wasting money, we're not wasting time, we're not putting people in the poorhouse, so to speak. We must also think about technologies. How can we use them? Right now, one of the biggest things that's saving patients money is a nurse and doing teleconferencing. We also have now computers where in some areas where the doctor looks at a patient through a computer and can see an ailment, or before you know it, they're going to have scans that people can scan their body and send it in electronically. We're also looking at cutting costs by putting everything across electronically. Now we have like the Epic where all the information is shared and you don't have the added cost of sending the information through the mail and having someone prepare all this work. It's actually shared in a shared drive. So again, these are some other things that we need to think about. How can we incorporate and evaluate new technologies to enhance the care our patients get while still keeping the cost down? And if you've ever done your own budget at home, you're going to think about some different things such as your operating budgets, your capital expenditure budget, and your cash budget, which is the money you have in hand. So the budgeting process is all about gathering information and planning. Think about when you do it at home and you're on a budget. Developing a unit and department budgets, and they all have to work within that budget. They were given so much money at a time. Then they develop cash budgets. What is our cash flow? What can we spend readily or what's invested? And then negotiating and revising. And sometimes we see that our budget, we're not spending it, so yes, we can decrease it. Or maybe, hey, we need more. We're scraping by and there's some things that we need. And when they see that you're using all the money that is budgeted to your unit, usually what will happen is they will increase that if the money is available. And then evaluating. Are we spending the money the way we should? Are we wasting money? What is happening to it? And how can we still work within the bounds of our budget? Okay, so that's all I have for you. Please make sure to read over that chapter so you have a little bit of idea about operating cost and budgets and healthcare systems and profits and nonprofit organizations.